Hi, I'd like to welcome everybody this evening on the East Coast, 4 o'clock on the West Coast, to ALPS webinar. For those of you who are not aware of who and what ALPS is, we are an organization whose mission is to end preventable amputations over the next generation and to also be the global leader in multidisciplinary diabetic and PAD foot education. So tonight's webinar is right in line with what we do, multidisciplinary strategies to accelerate healing and patient amputation and prevent amputations. We're excited tonight to have Dr. Kate McGinnigal, Dr. Cy Dove, Karen Bauer, and Dr. Lee Rogers. Next. If you are not currently a member, you can join tonight for $1. Just use the code WOUND, WOUND, all caps.
One
We would
dollar,
love
Georgia Craybill?
$1, Dr. Armstrong, $1.
What? What the heck? This is
We
great.
would love to have you become a member to learn more about our organization, our many conferences that we're doing all over the world. So please join with us. And I'm going to let Dr. Armstrong tee the next thing up, and that is the wound care alone is not enough. Dr. Armstrong?
Yeah, ladies and gents, it is such a pleasure to be with you today. You folks all over the world, whether it's in the United States, whether it's outside the US. And I mean, I know many of you share this evangelism that some of us have that are on this call in that it this problem is getting bigger, not just in the US, not just in the Europe, not just in the Middle East, but really worldwide. And it's not one individual clinician that can make a difference. No woman or no man is unto themselves an island. This takes a team. And we have to marry the team with technology and tenacity. And I'm telling you, those three T's are on full display today with the assembled brilliance that we have. Present company for sure excluded here on this webinar. I can't wait to listen to these characters. And again, we welcome you to join this family. You already heard from Georgia Craybill. This or ALPS started during the pandemic. Now there's more than 2,000 people that have joined over the years. This is crazy. I never thought it would get more than a couple of dozen, but now these true believers are all coming together. Toe, flow, nursing, at physical therapy, and other patient advocates. I mean, it really is taken off, and it's just life affirming stuff. I hope you share that with me, ladies and gents. I'm going to give you back to Georgia Craybill, and then we're going to move on to this terrific webinar.
Thank you, Dr. Armstrong. I think we're going to turn it over to
You are
Dr.
welcome.
McGinnigal. Yes, thank
Before we
you.
do that, is that true? It's just $1?
It is just $1. Can you believe that? Not normally. But tonight we're running the special infomercial here, running the special. So
I think McGinnigal joined for more than $1, but there we are.
don't tell anyone. I know.
Okay, I will not.
So I am going to turn this over to Dr. Kate McGinnigal.
All right. Hello, everybody. Thank you so much for tuning in today. I did join ALPS for more than $1, but it was still the best money I've ever spent. So I hope to see you at our next meeting. And, the question that was posed to me is who owns the wound? And, my first response is, well, all of us and none of us, but somebody's got to be in charge. And so I think for every individual patient, there's somebody who acts as the quarterback of the team, if you're an American and watch American football. But we all have to be involved. And the reason for that is because if you look here at the trends in limb amputation, back in 2000, when I was starting, amputation diagnosis was basically CLTI alone. This was ischemia forward disease, and that has been steadily decreasing over time. And instead, what's happening is more and more and more patients are having CLTI plus infection. And this is really driven by the increase in diabetes and the increase of infected diabetic foot ulcers that's layered in with peripheral artery disease. And so it's a lot more complicated now to treat vascular disease as a vascular surgeon, I can't necessarily own the wound all the time because they're a lot more complicated. It's no longer the days of a little bit of distal toe gangrene and me doing a bypass or a stent and cutting off the distal toe and being done. And so with this, I'm going to move on to the rest of my slides and give you a little bit of vascular perspective, keeping in mind that a lot of this is married in with diabetic foot. Luckily for us, we do have the SVS Wi-Fi score, and that helps us organize the extent of the wound, the extent of the ischemia, and the extent of the infection to help figure out who needs to be leading the game. But people need to be thinking about an expert in each of these three domains to really get a limb salvage. Next. The issue is that if you're seeing the patient for the first time, they're likely in the podiatry or the wound clinic because they've got a diabetic foot problem. And assessing for PAD and diabetes can actually be really challenging. A lot of these patients will have completely normal pulses and will not have vascular disease, but about half of them will also have vascular disease. The problem is that in diabetes, you get calcified blood vessels, and so simple tests like the ABI is not accurate. It's probably falsely elevated and appears to be normal even though it's not. You can mitigate that some if you have a more advanced lab and you can get a toe brachial index, or you can get a transcutaneous partial pressure of oxygen. But I will say that these TCPO2 tests, for as good as they are at assessing skin perfusion, they're actually not a very good predictor of ultimate wound healing compared to the toe pressure, which also is not that great. And then, of course, there's duplex ultrasound. But at that point, if you're going that far down the algorithm to try to figure out if somebody has vascular disease, I hope at that point, as a non-vascular person, you've already made the referral. Next. One of the things that we in the vascular space think about is how do we get better blood flow? The largest trial done in patients with severe PAD was the best CLI trial. It was 1,800 patients over 160 centers, and it ended up showing that people who have saphenous vein bypass do better and have less adverse limb events compared to people who get endovascular therapy. There's a lot of caveats to this, and there's some, nuances and complex decision making. But if you're in a situation where you only have access to endovascular therapy, do keep in mind that sometimes reaching out and meeting a vascular surgeon who can do bypass is in the patient's best interest. But probably more interestingly, on the next slide, we can see that everybody did kind of poorly in this trial. And so if you look at the outcomes here in cohort 1, the vein bypass patients, which are here in the first orange bar, 42% of those people either had a major adverse limb event, which means redo vascular surgery, a leg amputation, or they died. And that was worse in all of the other arms of the trial. And so everybody is sick. Everybody has a high risk of limb loss and death, and everybody needs all hands on deck to help them survive. Next. And so the practice that we have adopted is that if a patient has a toe pressure greater than 30, so that means mild to moderate ischemia, but evidence of vascular disease, we give them a 1-month trial of wound healing. And whether that's in the wound care center or directed by one of our podiatrists, we don't do anything on the vascular side at first. And if they start to heal, fabulous. Then it's probably a diabetes forward problem rather than an ischemia forward problem. And I can step back but be available if needed, because if the healing stalls or they don't heal, then I need to jump in with a revascularization plan, or based on all of the other kind of patient factors, maybe they're not a good candidate and the wound's not painful or infected, so we can just do a palliative wound care and keep them stable. Or maybe it's so advanced and the situation is so bad, we just move to leg amputation. And so this is the practice that we have in our Limb Preservation Center at UNC. Next. And there's not a lot of prospective data to back up that practice plan, but we have done a lot of retrospective work, and we've shown through a variety of publications throughout the years that limb salvage is definitely attainable with wound care alone, and that it's the size of the original wound that really predicts whether the wound's going to close or not, and only those with severe PAD need revascularization. Next slide. Another group also using this stepwise process of using deferred revascularization only if and when needed also had really excellent results. They found that that 1 month trial of wound therapy in those patients with mild to moderate ischemia did not result in worse outcomes. And even if those patients needed to move on to get a later revascularization, their wound healing time was still about the same at 4.5 to 5 months. Next. And here, this is hot off the presses. It just came out a month ago. This is a combined study between my group at UNC and also the group at Baylor. Again, looking at the patients with mild to moderate disease and what their outcomes were, whether wound care only, early or late revascularization. And on the next slide, you see that with good patient selection, the people who had late revascularization, which is the red line, actually had better survival. And I personally believe that that's because they got plugged into our system, where they got medically optimized, they had a wound plan, they had their infection controlled, and when they were truly optimized, then they went on for revascularization. And there is a survival benefit that's potentially noted there. Likewise, you can see that the patients who either had conservative palliative wound care or late revascularization had similar limb amputation rates, but limb salvage was lower in those who rushed straight off to get revascularized. And so this is all retrospective data, but I think it really shows that teamwork saves limbs, teamwork can impact survival, and it's worth prospective study. Next. And a lot of times I hear, well, we'll just do something really quick to try to get the blood flow a little better to that wound just so we can get the wound healed. And it doesn't really matter if that vessel stays open. But it turns out that if you revascularize someone, the wound healing time is really no different. But having a durable revascularization reduces the risk of wound recurrence. And so it really is important to pause and make a plan for the best long-lasting revascularization possible for the patient. Next. And so in conclusion, it's complicated. It needs a team. I need my friends. Diabetes is making it ever more complicated, and you can never underestimate the importance of the wound care, the infection control, the medical optimization. And you should be selective with who you're revascularizing, ideally with saphenous vein, but there's nuance there, and so it's worth talking it through. And if you're not a vascular surgeon, it's completely reasonable to ask your vascular surgeon or other vascular interventionalist why they're doing what they're doing and what they expect the outcomes and durability to be. So thank you.
Hello. Kate, I like what you just said. You need your friends. And as I tell my 9-year-old, sharing is caring. So who owns the wound? We all own the wound, but we all share the wound as well because we know it takes a team to manage these patients. Next, please. Let's see, I think Georgia, thank you. So I want to approach this as a podiatrist from the standpoint of what specializes us or differentiates podiatry from the rest of the pack, in that I like to think of us actually as stewards of the wound, because we see these patients pre-ulcer, during their ulceration, and post-ulceration. So we have a role in terms of early detection, and something that's really special is we know the mechanics of the foot very well, going to podiatry school and having these specialized courses, and we understand what it takes to keep the wound healed. So it's not just about healing the wound, it's about having durable wound healing and looking at the mechanics of the foot to see what we need to do to keep it healed, whether it's with bracing or whether it's with some type of surgical offloading. Next, please. See, I see I'm preaching to the crowd because I see Dr. Armstrong nodding his head. So something I think that as practitioners, we really need to understand is that the foot really is just a manifestation of systemic disease. We know the magic ingredients. You have a diabetic patient with neuropathy, and a lot of them have some level of ischemia and deformity, and that spells a disaster. But if you have a patient who has a rigid deformity, such as a bunion deformity or a hammer toe or a calcaneal gait, this small problem, this hammer toe, can become a catastrophe, especially when they develop an ulcer and they have concomitant peripheral arterial disease. That's when we need our friends like Dr. McGinnigal to come in with their cape and save the day for us. Next. So I always say to the residents and the students, if you can control the mechanics, if you recognize those mechanics early on, it's not just about treating the wound, it's about looking at the vascularity, the infection, but the offloading, because how many of us have had patients, we heal them up, and by the time we let them ring the bell in a wound care clinic, they walk out to their car and they have an ulcer immediately, because maybe we didn't really think about the mechanics of their foot and make sure we had measures to mitigate them having an ulceration, re-ulceration. So from a podiatric standpoint, we want to think about pressure redistribution. A lot of these patients, you cannot offload them no matter what you try, whether it's a crow walker, a TCC. Sometimes the only solution is surgical offloading. And then most importantly, which I think we are not doing a great job of in podiatry, is surveillance. We want to treat these patients after they've had a problem, but I think that we have to embrace technology. And David's camera is off, but I'm sure he's nodding because he is a tech guru in this space. But we have to start embracing technology and surveilling the wounds better so we can get to the patient and prevent problems by using all of these new tools that we have. Next. So, we have Dr. McGinnigal, our Flow-Migo. Karen, I'm sorry, I couldn't think of a good term, but I termed you Grow-Migo, Pro-Migo in terms of wound care. But podiatry, really, we are taking a journey with that patient. So Dr. McGinnigal is going to see the patient in an acute episode and maybe see them yearly once they're stable. Karen's going to see the patient when they have that acute episode. But podiatrists, when it's a diabetic foot ulcer, we see these patients forever. And that's why to a podiatric specialist, longevity and durability of healing is so critical. Doesn't matter if we heal the wound, if it's not durable or if it's not a functional limb, what do we really accomplish if we heal it and they're going to be on this merry-go-round coming back over and over again with the ulceration? Next. So again, just to reiterate, closure means nothing if it's not durable. We want to get these patients back on their feet, working, taking care of their families, enjoying life, and hopefully extending their life by giving them a more active lifestyle. And again, I'm a big fan of surveillance. So we have a lot of new tools nowadays for remote monitoring. We have lots of tools for pressure analytics that the patients can use at home or in the clinic. And also, any clinic that's treating patients with diabetic foot ulcers, they should have a post-closure algorithm so that they can monitor the patient and prevent the problems before they start. Next. So from a podiatric standpoint, we see that patient acutely and we work with our teammates. We're sharing the wound. But again, from a podiatric standpoint, we're with these patients forever. So we don't want to just think of or managing that acute episode. We're looking at the risk, especially from a biomechanical standpoint, so that they don't have a new ulceration. Thank you. Next, I think it's Dr. Bauer's turn.
Awesome. Thank you guys so much. I think, it's always wonderful to have these sessions. And I'll say that even after I've been doing this for so long, I learn every single time. And I love the Grow Migo. I think we're going to have to stick with that because what are we doing in wound care, right? We're growing tissue. So I think that was really great. I appreciate both the perspectives so far. We've already talked about the pillars of limb preservation. But like the theme has been tonight, it is always a team effort. So we're familiar with the toe and flow, but kind of what happens in between there. And the perspective that I want to give today from a wound care standpoint is one involving the patient and family, making sure that as we talk about the revascularization decision, as we're referring on to podiatry, infectious disease, plastic surgery, vascular surgery, we're making sure that we involve the patient and the family and they understand how they're traversing the system, as well as community members. So I think so often we get kind of tied down in our little circles, but making sure that we're involving home health, extended care facilities, and other community providers, and that we pay detailed attention to the wound care because these patients are traversing a very confusing system, right? So this was our system in Toledo, Ohio, from where I hail. And you can see, I mean, these patients are inpatient, they're outpatient, they're at the extended care facilities, they have home health, then they're back inpatient, they're going back and forth between all of these different services. So as we're talking about who really owns that, right? Who coordinates that? Who makes sure that as the patient's walking that journey, they don't fall through the cracks? So the goal is to have no limb loss to that siloed care. Limb preservation, I always say, is the keystone of a fragmented system. It really uncovers some of the shortcomings of our system, and it takes a team. And as Dr. Armstrong mentioned, us being relentless and working with our systems to make sure that we have that catch-all or that safety net. I also like to talk about how wound care often bookends limb preservation. Sadly, a lot of these patients don't come in until they have tissue loss or until they have that wound. They'll kind of overlook the pain or the claudication symptoms as a normal consequence of aging. They talk themselves out of it. They wait too long, and then they come in first to that wound care center. And then, as Dr. Dove talked about, we're seeing these patients forever, right? So even after they're revascularized, we get a wound closed, they're most likely going to be back. And these multidisciplinary teams, wound APPs, nurses, physical therapy, as Dr. Armstrong mentioned, are perfectly positioned to help facilitate these workable systems and coordinate that care as the patient kind of bounces back and forth. So the research is there. We know that adding wound care to any vascular practice is going to be beneficial not only for the outcomes when we look at amputation rates, mortality rates, but also our financial looking at that. So adding wound care to our practices, having access to a wound care clinician or a wound care center can improve outcomes on all levels. But with that, as wound care clinicians, we don't have one set of guidelines, right? So as we're seeing patients, we have to make sure that we're in tune with the IDSA guidelines, the International Working Group for the Diabetic Foot guidelines, the SVS guidelines, so that as we're seeing these different types of wounds, because we know that wounds don't occur in a vacuum, right? It's very rare that we will see a purely ischemic wound. Oftentimes these patients are diabetic, they're end-stage renal, they may have a venous component. It's really important that we kind of pull in all of those disciplines and make sure that we're approaching this from a multidisciplinary standpoint with regard to our clinical practice. So with that, we have to cast a really wide net as we're seeing these patients. Again, these wounds are not occurring. Very often they're going to present kind of in a mixed way. It's important that while we're in a field of horses, we have our zebras in tune, right? That we're looking for those things, but not too hard. But that even as we're seeing wounds that may appear purely venous or purely ischemic, we have on our radar what else is going on when they're not healing. One of the other ways that we can help as wound care clinicians, and something that we've been talking heavily about right now, is wound bed prep, making sure, as Dr. McGinnigal said, that as we're seeing these patients, we're paying attention to the wound hygiene, that we're cleaning the wounds really well, that we're serial debriding or using integral debridement, which is where we're using multiple modalities to try to keep the bioburden down and make sure that we're really paying attention to those nuances. And as these wounds do improve or don't improve, we adjust frequently. So this isn't something in wound care we can kind of stand at the door and say, oh, that looks beefy, red and nice, and go on our way. We really have to get in there and look at all the modalities that can help and take that extra step to do the little things that will actually end up being big things when we look at the wound healing trajectory. So with that, we do have some frameworks that we use. We're all familiar with timers. Another one that we've been talking about in the literature recently is biomes, where we're starting to look more holistically at the patient from a wound care standpoint versus just the wound bed itself, but also making sure that we're diligent with regard to our topical therapy. We know that dressings aren't going to be the thing that heals the wounds on their own, but that as we select dressings, we have to use our science. We have to use what's going on with that wound and tweak it. A lot of times my patients will feel like they're a science experiment for me because I might change what we're doing with their wound, every week or every other week. And it's explaining to them that we have to really adjust to what's going on in the local wound environment and address that appropriately, because there's hundreds and thousands of dressings on the market, right? So how do we know when to use what? And unfortunately, you can see there, we kind of laugh at that. That's a Kara Couch picture, the Chipotle napkin, but the patient's using logical sense and trying to absorb his exudate, right? So we have to make sure that we're familiar with that, but that as we do that, we have to make sure that our patients actually have access to what we're trying to get them. So kind of the case for wound care as a coordination hub, we have unmatched touch frequency. So Dr. Dove mentioned earlier, how often she's seeing patients, very true with us too, that we're seeing these patients sometimes more than once a week. If they're doing hyperbarics and we're in that clinic, we might be seeing them daily. Generally, as wound care providers, we're going to have holistic and systems level training. We can serial debride. We've mastered those dressings, which is really important, that detail, like I mentioned. We're in tune with some of the technology that Dr. Armstrong mentioned, making sure that we're using some of the new things to help us with perfusion and bacterial imaging. But I think also important in this discussion is making sure that we really connect these patients to the community and we connect ourselves to the community, because it doesn't matter how great we are in clinic or in surgery or in the hospital. If the patient goes home and doesn't get good care at home, then everything that we do there is for naught. So with that, there are some studies that show that having a wound care provider jump in does improve wound healing statistics, obviously, but also limb preservation. There aren't great studies to show this in large numbers. We do lack that in wound care, but we are starting to see more and more come out about the role of a specifically wound trained provider on a limb preservation team. And in summary, it really does take this team. Our goal is for transdisciplinary versus multidisciplinary. So when we look at that from a perspective of, we may have podiatry or we may not, we may have infectious disease or we may not, we may have access to vascular surgery, we may not, but really what we need to be doing is not having those care be siloed. And like Dr. Armstrong and others mentioned tonight, calling a friend, making sure that we're really having discussions around the patient's care and what it means for the patient. And your team may look different, right? So you may not have podiatry, you may not have access to infectious disease, right in your local jurisdiction, but it's important to have those friends that you can call. I always say, be willing to phone a friend or have five, right? I got really good at cold calling in my career simply because there were so many times that I'm calling rheumatology or dermatology because I don't know what I'm looking at. So it's really important to have the courage to do that. So with that, I will turn it over. Dr. McGinnigal has a case that we're going to discuss kind of from that interdisciplinary or transdisciplinary standpoint.
Yeah, so this is a patient that I took care of, and I don't actually work at the same place as anybody on the webinar, and so this is a bit blind for them. But it's something that I think is a really complex but frequent patient type that we all see, and I'd love to kind of get input. And so this patient, it was a 57-year-old male who had diabetes with a long-standing neuropathy and bilateral Charcot. He was originally seen by his primary care doctor, who sent him to our complex podiatry clinic and to a local vascular specialist. And so our podiatrist got those foot x-rays that you see on the local vascular specialist. I wasn't involved yet at this point. Got a workup and noted that the ABI was only about 0.5 or 0.6, and the toe pressure was only 30, and there was a popliteal occlusion. And so this patient was, I think, planned to get revascularization of that popliteal occlusion because he was going to, be getting worked up for a bunch of pretty big podiatric surgery, and we wanted to improve the perfusion because that toe pressure of 30 is really the cutoff where the ischemia becomes a big problem. And so he got that done. He got his procedure done elsewhere, came back to our podiatry clinic, ready to go, but obviously had failed outpatient management. And so at this point, our podiatrist brought him back to the OR to debride all of that gunk out of the base of that wound. And I ended up getting repeated duplexes and having to take him to interventional radiology to do an endovascular revascularization. But if you anybody else could chime in, do you see this? Is this, it's a fragmented care a little bit, maybe some back and forths. I hate that a patient who came in to get care at our center ended up being in the outpatient space for so long to devolve into this awful wound. What would you do if you saw this in your clinic?
Well, Kate, you know what I love about this case? It's Charcot, but with overlying PAD, and a lot of young doctors, podiatric physicians who are hungry to take this case to the OR, they don't always do an adequate vascular workup. So the fact that this was caught before this patient had an external fixator or frame put on them, that is a good catch. And I do think that you work with what you have, like Karen said, transdisciplinary care. I love that because your care is going to depend on what setting you're in. So I think the approach was good. You work with the tools that you have and the people that you have.
I agree. I will say, oftentimes as wound care people, be it podiatry doing wound, infectious disease, vascular, whoever's doing the wound, we get so caught up in treating the wound, right, that we forget about the patient. So I agree that, catching that and revascularizing early is really important. I think my question there is timing. And I think this varies by institution and provider, but what is your input on, Dr. McGinnigal, you revascularized. Dr. Dove, you want to go ahead and do some reconstruction. When do you look to time that? And how do you communicate that, okay, they're revascularized, they're ready for you. And then you say, well, I might not be ready for them. What does that look like in your practices?
Yeah, so we have a weekly conference that we call PALS, which is Peripheral Artery Limb Salvage. I made up that acronym before ChatGPT existed and could make up catchier acronyms just, at the snap of a finger. But we have a PALS conference, and my Tomigo and Woe Grow Migo wound care professionals all call in and talk about these types of cases. And so that way we can all try to kind of rearrange our schedules and line things up for patients who are kind of in a kind of an acute crisis mode with their wound, or patients who are kind of like bopping along and stalling out with what we thought would be a reasonable plan. We all kind of like review the chart and figure out if we missed anything. But, in this case, the patient was seen by our podiatrist. They wanted to, do an orthopedic correction, but they wanted better blood flow. The patient went and got better blood flow just by his local, vascular specialist, I think within a couple of weeks. But then by the time the patient came back for the pre-op appointment to get worked up for the orthopedic surgery, they took down the dressing and saw this wound and like couldn't really find Doppler signals. And so they were like, whoa, whoa, whoa. Luckily, we have a clinic that's all connected. And so they ran across the hallway and they came to get me. And I think we actually have a couple more slides. Do you mind advancing to the next slide? Um, and so, oh yeah, this is everything I've just been talking about. Go on to the next slide. Okay, and so when we repeated the arterial duplex study, that popliteal occlusion that had been balloon angioplastied was occluded again. And that's because the vascular intervention was not really durable. And that's a really tricky spot. And so, Dr. Dove, you mentioned that sometimes podiatrists miss the PAD, but here in this case, they actually caught the PAD, they had the diagnosis, they got it treated, they thought they were in the clear, but the intervention had failed, right? And so, and I think the wound getting so bad and kind of punched out like that clued them in that something wasn't quite right. But if the wound hadn't turned like that, then they could have been in trouble. And so it takes a lot of people double checking. And so if you go on to the next slide. So here is what his angiogram looked like. And so on the far left, you can see his popliteal artery is kind of at the top of the screen, and it comes down as like a normal gray line, and then it kind of quits. And so that's the stuff that had been treated that wasn't patent anymore. But eventually, he actually had three vessel runoff to the tibials. And this is an IVUS picture. This is ultrasound from inside the blood vessel. I use this a lot in the more complex patients or patients who had an early failure after a vascular procedure to really get good measurements and to tailor my treatments. And so then I was able to intervene. And if you go to the next slide, please. And, just used a little bit more of an aggressive approach to fixing the popliteal artery. And you can see my initial intervention is here in the black and it's open again, but it's not exactly perfect. I did a little bit more work, and that middle picture that's white, that's just poorly timed contrast. Like it went down so fast. I didn't step on the pedal at the right time. So that's a total rookie move, but the contour of the vessel looks a heck of a lot better, and there's better flow down into the foot. Um, and he started to heal his wound. Um,
But Kate, you're living the dream. So you have podiatry and vascular interconnected. So I mean, a big part of it is just the proximity and good communication. Because what if that podiatry team was offsite 50 miles away? They said, well, vascular study's good to go. We're going to put this frame on, and it would have been a catastrophic disaster. So you save this patient from having a procedure too soon with the team and the communication, which is that's the dream, really, right?
Yeah, if I may say so myself, we've got a really, really world-class setup here.
I think that's something to like coming from the wound care perspective is making sure that our wound care providers are vascularly trained to
Mm-hmm.
some extent, right? So that I don't know that people realize the durability, right? And realize that sometimes these patients are re-stenosing, re-occluding rather quickly and understand their
Mm-hmm.
surveillance imaging. So that was something that I'm lucky is that our APPs and even our vascular surgeons were dually trained. So somebody asked earlier, kind of in a chat, who's doing that 1 month, 6 month surveillance. And I think that wound care, again, whoever the specialty is, we're seeing those patients so frequently. What an opportunity and a touch point to make sure they're taking their statin and their Plavix and their Xarelto and, make sure that they have their surveillance studies. But I think to do that, we really need to marry these specialties and make sure that our wound care providers who don't have a Dr. McGinnigal or don't have a podiatrist, those doing the wound care really understand these principles.
Yeah, and I will say, I'm at a large academic program with a long history of working in limb preservation. But it still takes an extreme amount of energy and effort to keep it all together and to keep everybody mission driven and focused in the same direction. And ideally, and even potentially through ALPS, we'll build up some really big centers like mine, but then also figure out how to make it a lot easier for people who are a little more isolated, who don't have a friend across the hallway, to be able to rapidly, get in for an expert consultation. And there's a lot of different modes and mechanisms by which that can happen. And of course, all local situations are a little bit different, but I think that's what it takes. And even for folks like me who are, sitting in the midst of a ton of specialists, like it's a lot of effort. It's a lot of effort. But when you're in a group of people who all believe the same thing and are, mission driven, it's totally worth the effort and it's fun to do.
Yes, agreed.
Kate, I'm really glad to hear you say that about ALPS because that's exactly what we are in our networking platform. Or David, what do you call it?
I can't believe you're asking me. You told me I shouldn't say this statutorily, Ms.
I'll let
Corby.
you.
I am going to say it now. I've been released from my responsibility not to say it. I call it a cross between a dating app and a marriage counselor for clinicians that really care about this problem. And that's really how ALPS was born because there weren't folks really doing that in the different professional, medical, surgical, nursing or other organizations, and that has been the magic. But just like you heard, I'm going to shut up here. But You heard from every single person here, from Karen and to Cy, that, and for sure, Kate, that, this stuff, it's hard. But just because it's hard doesn't mean it's not worth it, right? It doesn't mean it's not worth like a life's work. And I know people wouldn't be on here in an evening or late afternoon if they didn't share that same kind of enthusiasm. But that is the kind of thing that you sort of get when you build these sort of clinics. But the magic is when you put that together, you got to keep it working, and you got to keep just like Kate said. I'll shut up now. I'm going to shut up because she said everything. Shutting up.
Thank you, all three of you. It's been wonderful to hear about, how you work in a multidisciplinary team. Now we're going to turn it over to Dr. Lee Rogers, and he's going to talk about the role of intact fish skin technology in a multidisciplinary protocol. Dr.
Yeah.
Rogers, are you with
By the way,
us?
no smoking, Lee Rogers. There's no smoking allowed on the.
I am on fire, David Armstrong. Great to be here this evening, and I'm, it's wonderful to hear everybody else's experiences and really where they've had their difficulties and their successes putting together their teams. This is something that I've put together at numerous places. I've written a lot about this with Armstrong, and so these teams and the friendships you create out of these teams are going to be lifelong, and create your network around the world doing that. So, and it's really because of our passion that we have towards this. So, I'm going to talk about a little bit about some. It's not really about the technology, but it's how technology and biotech fits into your current algorithm in your team and your multidisciplinary approach. Because it's really about the multidisciplinary approach that makes the biggest difference, makes a bigger difference over any potential product or any type of technology that you can use. It's about people getting together and knowing when it should be used and how it should be used in that right setting in that patient. So in this case, we're going to discuss some complex wounds and how we take these complex wounds and make them simple through this whole team concept. So the first thing I want to discuss is the Odin trial, and the Odin trial was a trial on looking at fish skin for deep diabetic foot ulcers, and so this is a problem that we all face. There hasn't been great evidence in the past on what to do for these deep diabetic foot ulcers. These are ulcers that extend down to tendon and down to bone, and where all of us have probably used various what used to be called skin substitutes, and then were called CTPs, and now are called CAMPs, where we've used these different tissues to place over this deeper tissue in order to get some granulation, fill it in, so we can either move to the next step or heal it. We've all done that, but we haven't had great evidence in the past, and now we do, and this is where we're going to discuss this Odin trial. So the Odin trial, it's named after in homage to the Norse god of healing and knowledge, and it was an open label randomized parallel group trial of 262 patients, so the largest trial in deep diabetic foot ulcers. It spanned across 15 centers, so it was multi-centered across Europe. It took place in 2020 through 2022, and it was looking at UT grade 2 and 3 ulcers. These are ulcers that go down to UT grade 2 would be down to tendon or muscle or fascia, and then UT grade 3 would be down to periosteum or bone, and it used fish skin plus guideline-based care. So versus the standardized international working group on the diabetic foot-based care. So this is, in my opinion, really better than standard of care. It's guideline-based care looking at the difference between in the healing rate at 12 and 16 weeks between those two. It did have an externally blinded committee to judge wound healing, since it's hard to do blinding when you're the surgeon doing this. So it's the largest randomized controlled trial on these deep diabetic foot ulcers. The results showed that in grade 2 ulcers, there was a 47% healing versus a 23% closure at 16 weeks in grade 2 ulcers. In grade 3 ulcers, 33% versus almost 20% at 16 weeks. And you can see that the differentiation happened relatively early. I'm not sure if my pointer's working here, but it's there about 6 weeks or so. You can start to see the trending toward healing. So one of the things that we have to think about is, what is our goal of using a various camp in wound healing, in limb salvage for a particular patient? Is this something that we are looking to get total epithelialization for, or are we looking to cover bone and tendon so that we can move to the next step, which is often called bridging therapy, where we're bridging to that next step? So there's a difference in really the acute surgical applications of camps and then those that are used in chronic wounds in the outpatient setting. So the acute surgical applications, these are generally very large wounds that they are coming in usually as gangrene or infections. They become a wound because you perform source control to remove the gangrene or the infected tissue, and you're left with a big ulceration. I'll say that there's really nothing that replaces that standard approach. And we do this at UT just like everybody else has described, where you have your vascular component, your podiatric component, your nursing, the wound healing side, physical therapy involved, all of this team put together looking at this wound. You're still going to go through all of these steps, but when you're starting out with that massive infection and you're doing source control in order to control that infection, then you're left with a large and complex wound. In that case, these types of tissues, and fish skin in this case, is generally used as a single application with negative pressure wound therapy. It's used to cover bone and tendon, and the goals of therapy might be a little bit different. Maybe it's just to get granulation tissue over that deeper tissue so that we can then move on to something else, maybe a split thickness skin graft, because the wound is too large to be treated in successive applications in an outpatient setting. But in other cases where the wound is smaller, it's appropriate to do successive applications, move them over to the outpatient setting. And that's where we're dealing with what we typically would refer to as chronic wounds. And those are done in the outpatient setting in clinic, where the graft itself is used for the purpose of epithelialization. So I'll draw your attention to this, and if you're on your phone, you won't be able to do it, but if you're on your computer, you can take a quick screen capture and grab this QR code. This is the international consensus on achieving limb preservation with what is now called CAMPS, but it's cellular, acellular, and matrix-like products. And this is a great document. I was part of the authors of this document. Is led by Wendy Cole, and it outlined really everything you need to think about in a limb preservation patient, and looking at the patient as a whole and what needs to be done in order to achieve limb preservation and wound healing. So in this document, we talked about these differences between the uses of CAMPS. Not only CAMPS can be used to epithelialize a wound. And like I said, these are typically smaller wounds in area that are done in the clinic, but it can be used as a bridge to final closure when you're doing this as in the surgical arena, in order to get granulation tissue over that deeper bone or tendon or muscle, so that you can get a wound that's granular and level with the surrounding skin to move on to the next step. One of the things that we did stress was looking at the various camps and their indications, and looking at the etiologies of the wounds. And so some camps are better and indicated for certain etiologies. Some are indicated for others. Looking also at the depth, there's various descriptions in the instructions for use on whether camps can be used over partial thickness, full thickness wounds, whether they're tunneling, if they have exposed tendon or muscle or joint or bone. And so it's important to look at all of these things and see which one you anticipate using and what your overall goal is of therapy. So and then some are also indicated in various lengths of chronicity for the wounds. So some wounds that are greater than 3 weeks, 4 weeks, 6 weeks. So go ahead and read the instructions for use to really make sure you have a firm handle on which camp to use and when. And this is the approach we use at UT. It's actually no different than what I've heard from everybody else here. And the team-based approach, I'd say my probably the person that's actually their number one on my phone list is my vascular surgeon. Luckily, it's a 60-year-old guy. Otherwise, my wife would accuse me of infidelity. But Armstrong, it's probably not infidelity. It's probably being very you're being really faithful to your toe and flow marriage that you have, with your dating app. So my vascular surgeon is probably my number one person that I talk to every day.
Love is love, Lee Rogers. Love is love. And it's okay if you have a throuple, a polygamous. This is your therapeutic family. Love is love.
It's great. And I think it's probably more the merrier in this case when you're dealing with wounds. You want to have a big team and get as many people that love that wound as possible. We talked about owning the wound. Nobody should own the wound. We're just leasing it. We're going to give it back at the end, and that's what we're going to do. So people ask often, like, what's the appropriate case for the use of fish skin or any of these camps over a wound? And you look at all of these wounds, and you look at them, and I don't know what you would say, but I look at these and I say, these are all appropriate wounds. They're just not appropriate right now, but they are appropriate after we've done an adequate job of source control or removing necrotic tissue in order to get back to healthy tissue. And we're talking about, in many cases, these are wide margins around the wounds. This is almost like, we talk about the outcomes and things like mortality and its relation to cancers and other things. But this is like a cancer in the soft tissue. You've got to get all of that diseased tissue out, whether it's infected or necrotic, and get to a healthy bleeding level so that if you're going to use a camp, and you're going to use fish skin in this case, it's going to work. So just a couple of really quick cases here to demonstrate how we get something that you look at and you say, oh, that's not a graftable case, and you get it to a graftable case, which then brings you on to ultimate closure. So this is somebody that presented to the emergency department with an IDSA severe diabetic foot infection, ended up with source control. So we start out with a UT3D ulcer. So this is an ulcer with osteomyelitis present on X-ray. So that's a UT3. It's infected, and the surrounding tissue is infected, and they also have systemic signs and symptoms of infection. So that leads us to an IDSA severe, but it's a UT3D ulceration. And we can convert that now with an open amputation and a wide debridement of all the infected tissue especially when you see infection that's tracking along this fat, when that fat's necrotic and that fat's discolored and it's not bleeding, you got to remove all of that, including the skin overlying it. That's not going to heal. And you're just going to end up doing multiple debridements in the operating room, or risking a higher level amputation if you don't take adequate tissue for your source control. So source control is so important in setting you up for success. And so we go from a UT3D to a UT3A. We've got exposed bone here. This is the head of the first metatarsal, and so there's cartilage that's present. Usually cartilage. It depends how much cartilage there is, but usually cartilage. It has a hard time granulating anyway. And so in this case, we put our fish skin on here. We use our negative pressure therapy over the top of it. We like to sandwich everything together, so it prevents leaks around the digits. And so then we get to, this is 3 days later after source control. We get to here where we're at 12 days, back in the operating room, do another debridement. We can see the fish skin's been completely absorbed. The first metatarsal head's completely covered here, but after our debridement, you can actually see the joint of the second metatarsal phalangeal joint that's exposed there, and there's a little bit of cartilage that's exposed. So instead of, this is not going to be graftable with a skin graft, so went ahead and put another fish skin on this and another vac. We're still at 12 days back in the operating room. Now we're back here at 22 days after we're back in the operating room again, but this is after that graft is fully incorporated and that tissue has grown over the exposed bone. And so our therapeutic goal has been reached in this case. So we're not looking for total wound healing. This is a very large wound. It would take months to get this thing to heal with fish skin or anything else over successive treatments. This is somebody we're moving on to a split thickness skin graft. So this is a bridging therapy, but we've achieved our goal of no exposed bone and level and granular tissue. So on to one other case, looking at this. This is a clinic-based case with exposed bone. So this is another case with a little exposed cartilage there, second metatarsal head exposed after source control with an amputation. This patient has already been using negative pressure wound therapy, and you can see the plantar area level and granular. This is in the arch-ish, kind of non-weight bearing. So this is something we're going to use a split thickness skin graft on. So we actually separated these two wounds and used two different treatment strategies on them. Split thickness skin graft on the plantar, and then in that area in between the third and the first, went ahead and used fish skin to get that to be granular and closed. So this is using it. You can see we're in the clinic setting here. We're not in the operating room. Get this thing closed and cover this here. We use Duoderm around the edges as a method to secure this. And securing a graft is always, if you're in between digits, very difficult. This is where your experience over many years comes into play on how to get these things to adhere and to secure them appropriately. And then this is using a digital planimetry to measure the wound over a period of time. Got the first application there about 8 centimeters squared, second application down to 6, third down to 4, fourth application down to about 3 centimeters squared, and this wound went on to total healing epithelialization in 41 days. And then here we are. This is several months afterwards, but you can see the quality of the skin closure here, both on the plantar surface with that split thickness skin graft, and that's a typical healing for a split thickness skin graft months afterwards, still dark in color, and less resilient to shearing forces and direct pressure. Heals a little bit thinner, but that's technically a non-weight bearing area. And then dorsally, where we'll put that fish skin in order to get that to granulate and then ultimately totally heal. That's got nice resilient skin. So last bit here is this was a subgroup in the Odin trial looking at the post-resection or amputation patients. There weren't enough patients in this section to actually get powered for statistical significance, but the numbers alone speak pretty well. They're looking at 16-week closure, 31% closed versus 16, looking at 24-week closure, 44 versus 30. And so you see all of these wounds here. This is something we typically use in exposed bone after amputations with an open transmetatarsal amputation. Sometimes you're not going to have enough plantar flap in order to close. You got to do an open transmetatarsal amputation. And so we can take wounds like this and graft them, get the bone to be covered with granulation tissue, and then move on to a split thickness skin graft in those cases. So in summary, this is Odin. He's dressed as a doctor. You know, sometimes we got he's a god dressed as a doctor. Sometimes we have other people dressed as gods who think they're a doctor, but we're talking about fish grafting, and applying a graft is like giving somebody a fish. But the team-based approach, which we can't lose sight of, is teaching somebody how to fish. And also the just as in technology makes fishing easier with fish finders and other things, we technology makes our life easier in wound healing as well. And then evidence and guidelines, these are equivalent to your fishing license. So you gotta follow the evidence and follow the guidelines. And we heard lots of talk about that with the International Working Group. The Wound Healing Society has guidelines. There's guidelines from Society for Vascular Surgery. There's guidelines. There's the limb preservation consensus. There's all these guidelines on wound healing, and you got to take them and adapt them to your current situation. And just as if you're adapting your situation to your team, whether you've got a vascular surgeon or an interventionist, who's going to be on your team is really dependent upon what skill sets you need. This was in the draft document. Armstrong was one of the co-authors. Ryan Fitzgerald was the lead author on that. It's surprisingly got a lot of play, that document, David. But it was published in ePlasty back in what, 2014-ish, 20 something around there.
That. Yeah, well before that.
And
I think maybe 2011 or 20, anyway, 2010, yeah.
Somewhere around there. So it's that document is the draft, DRRAFT. And it talks about how you identify the skills that are needed on your team as opposed to the people. So what skill sets do I need in order to achieve the goal of limb salvage? And it was about an acute foot team, but what skill sets do I need? And then identifying who can fill those various gaps. And that actually opens up a lot of possibilities to you, whether you're in an academic medical center or you're in a private practice in in a rural area, and you can form your teams, whether they're virtual or in person, or you've got, McGinnigal has somebody across the hall from her, or you've got somebody that's available by FaceTime. You can create these teams and really have a positive impact. And none of these things, they're all obstacles, but none of them are impassable in order to get your appropriate team together to achieve the goal of limb salvage. Get everybody on the same page and achieve that goal of limb salvage. Thank you.
Thank you, Dr. Rogers. Yeah, you've said that perfectly, and that's exactly what ALPS is here to do, and to be that conduit and to bring everyone together. AK, can we have that slide again? I think there's some questions about, okay, the code is wounds, so please sign up tonight. I think we'll have it hot and active for another couple of days. And I believe we are out of time. We're working on answering your questions in the chat, so we can still do that. But I wanted to thank everyone, all of our presenters here tonight, and thank our strategic partners, Kerecis. And please get us signed up and reach out to us. We're always here to answer any questions and put you in touch with other people and other teams. So please use this code WOUNDS and sign up for ALPS. Thank
Absolutely.
you.
And by the way, there's so many questions here. We'll try to get to each and every one of them. I
You want
know
to try? If
people were
do you want to
replying,
address one?
but I think we were replying to just the host and the panelist and not to there's stuff from, but maybe we can get to some of these afterward because of time constraints, but the questions from not only nurses, they were from podorthists. These were spectacular comments, as well as other clinicians and including podiatrists and others. But we will get to each and every one of these maybe in order subsequently, since they can't reply to all of these. But I just want to thank everyone for participating. These guys, what a bunch of stars. It was a lot of fun. Sitting back smiling. So I look forward to the next one. And it was even great having Dr. Rogers on there. I mean, I didn't know what was, oh, there it is. Is that like Red Bull or is that beyond Red Bull? It's Monster. Monster.
Sugar-free Monster.
Okay, there it goes. Yeah. Well, listen, everyone, touche or toshe, as we say, and we will see you for the next round of webinars. This was just great.